From a urologist perspective, I will say that the first thing what viewers can do is to drink liquids. Stone is a common problem that can be taken by a simple thing by drinking plenty of liquids, reducing salt in diet. Getting 2.5 liters of urine a day is a good thing which prevents formation of stone. Calcium intake is not linked to stone formation if you are taking them under medical supervision in the medical doses. Actually, a person once get a stone disease has a chances of more than 50% to get a stone again in couple of years. And the third thing which I told you is RIRS. It's one of the latest addition to the armamentarium of a urologist, in which we go from the natural orifice to the kidney. We tackle the stone over there, we crush the stone over there, and now suction is also available to suck the dust out of it, and the stone free rates of these two procedures are more than 90%. For old age patients, for the patients who have entered their 50s, early 50s or 60s, they should go for a preventive health checkup. They should not take any symptom lightly.
Big hello to everyone watching this podcast series. In this podcast series, we do a healthcare journey in a medical specialty along with an expert. I am Dr. Prashant Nag, VP Tata of LMG, pathologist by qualification. Today we have an expert, Dr. Rishi Raj Vohra, who is an eminent urologist. So we'll be traversing the field of urology along with Dr. Rishi. Welcome, Dr. Rishi. Just for the viewers and listeners, I'd like to tell, a urologist is a surgeon who manages diseases related to kidney, the duct carrying urine from kidney to urine bladder, that is ureter, urinary bladder, urethra, and the path ahead. So they deal anything from stones to renal cell carcinomas and big cancer surgeries of these areas. We'll take your guidance to take a deep dive on all the topics related to this.
Hi, Dr. Prashant. Great to be part of this podcast.
We look forward for these podcasts just to take patients to a journey where their common concerns are answered by a specialist. If you can just take our viewers through a journey, how stone presents, what all it takes.
Stone, it is one of the commonest thing in the whole world. 1 in 10 person usually get a stone in his lifetime. It is a dehydration which causes solutes to crystallize in the water and formation of stones. The sexual predisposition is more towards male. Around 12% of the males and around 9% of females usually present with the stone disease.
Okay, so by gender, it's the male which are more affected.
True.
Okay.
It is probably because of the work culture male goes. Most of the outdoor work are done by male, and more of the riskier work in the harsh environment are done by male.
So it's not the biology, but it is just the sociology of our culture which makes, because primary thing, one top message which I like my viewers to take from here is that it's the dehydration which is the cause of the stone, and it is at times work related, so that take it over there. So it is primarily an emergency condition.
The presentation of stone is usually in the ER room only. Patient comes to us early in the morning or late at night that he or she has an acute pain in the abdomen, more towards the right or the left side as per the location of stone. The pain is the commonest symptom which the patient presents in an emergency late night, requiring injectable painkillers for relief of pain. The pain is so severe, wherever he has to come to the hospital to get that pain relieved. Usually, sometimes it's associated with vomiting, sometimes severe nausea is there, bloating of abdomen is there. There is a sense of less of urine output with sometimes blood in urine, that is called hematuria.
So other than pain, it can present as just painless blood coming out of urine. Any other presentation which you see?
Usually, last night itself, we saw a young girl of around 20 years of age came to us with not able to pass urine since last 4 to 6 hours. She has taken multiple gallons of water inside, but still she says that my abdomen is blotting, but I am not able to pass. We got a screening ultrasound done in the emergency. The bladder was empty, but there was a small stone which was localized in the lower part of the ureter, which sometimes present as anuria, not able to pass urine, retention of urine.
And that is causing its own a different type of pain and in a different type of emergency.
Exactly.
As you said, that symptom is the first thing. It can be pain, it can be painless hematuria, that is blood in urine. It can be simple anuria.
Beg your pardon, actually painless hematuria is not there. Usually hematuria in stone is with pain.
Okay, so it's always with pain. Primarily it's with pain.
Yeah.
Okay. So moving forward, How do you investigate a case which is suspected of pain? Because abdominal pain is something which is very confusing. An acute pain can be appendicitis, acute pain can be multiple causes. So, how do you proceed with a person having pain in abdomen, primarily being suspected for a stone?
Any pain in abdomen which comes to the emergency is first of all taken with the ultrasound. The first investigation of choice in such cases is ultrasound. In ultrasound, it's not always that we see the stone. We see some changes of obstruction in the kidney, some swelling is there, that is called hydronephrosis is there in the kidney, or some radiopaque shadow in the kidney is seen, or there may be nothing.
Okay.
The ultrasound may be totally normal. Because ultrasound, the sensitivity of localizing the stone or getting the stone, specifically for renal stones, is not that great. In such cases, we advise patients to go for a CT scan. CT scan sensitivity is excellent, and most of the stones are taken up by the CT scan very easily, which can be read by a urologist or by the radiologist.
So your primary aim is for the visualization of stone. If it happens by USG, it's good. If not, then the investigation of choice is your NCCT, that is non-contrast CT scan. What all other investigations which you feel a stone patient go for, like a blood investigation and urine investigations?
We usually get a kidney function test done for such cases because stone, if presenting as pain, is with some obstruction in the kidney.
Okay.
There may be a chances that his kidney functions will be deranged. That can be an emergent situation to go for intervention.
Okay.
The other thing which we used to do is to rule out any infection of stone. For that, complete blood count is done. Urine routine micro to rule out any abnormality in the urine, like blood in urine or some pus cells are urine in there. Urine culture is done, but the culture takes a couple of days to come.
2 days thing.
Initial investigations are we go with this.
So practically it's a wholesome thing where you will try to visualize the stone, relieve the pain as a symptomatic thing, and parallelly investigate whether stone was lying there, doing some damage earlier, taking toll on the kidney, and if blood investigation throw some light over there. So moving forward, from what we have understood is that it is something which is seen in those age groups which go out for work and dehydration is the cause. So what all lifestyle things which you feel, because as you said that in male also it is the lifestyle thing which is bringing out the stone. So what are lifestyle things which you feel are primarily predisposing to stones, and what you like to tell our viewers how to take care of those things?
You rightly said that lifestyle is associated with renal stone disease because now we are health conscious. We want to reduce our weight. We frequently go to gym. We take some supplements for protein. But the problem with us is we like to go run a marathon, but we don't drink liquid accordingly. Okay. So the important part to prevent stone formation is to drink plenty of liquids. You should pee at least 2.5 liters of urine in a day. This is must for everyone whosoever is linked with such activities. Secondly, the urbanization is leading to late night hours, eating food outside which contains lot of salt, and not taking more of fizzy drinks that are cokes and all those things.
All the junk food is all about high salt content and cola drinks. So yes, I got your point. So it is primarily, it's not just the primary water intake, but overall water balance of the body has to be seen in terms of exercise as well as in the food part.
You already know that high salt intake will increase the osmolality, the overall that will lead to overall dehydration. That will lead to crystallization, and one gets a stone for that.
So just elaborating for the users as exactly if you feel that someone is working high, doing some strenuous exercise and all, how should he look at its water intake? What should be the periodicity on which one should think of water intake?
Actually, periodicity doesn't matter. It's a volume which we say that you should to drink. You should get 2.5 liters of urine in a day. If you are in a hot and humid climate, that may range to around 8 liters a day you need to drink. But the output should be more than that. 2.5 to 3 liters is quite good to take care of prevention of stone.
From prevention going to conservative management, is it always a surgical treatment which is required for a stone?
I just want to add one more thing. The stones are now prevalent in youngsters also, in pregnant females also. And those are the challenging cases for us. In pregnancy, we can't do any radiation thing, any CT scan can't be done, X-ray can't be done. Such patients are really in a dilemma how to manage, how to get relief of pain. In such cases, we take care of ultrasound itself, and a couple of ultrasound usually catches some hydrogen
Because
something
CT
like
scan is
that.
something which is
We can't do.
we can't do that over there.
In such
And
case,
how does management goes? But as it's all about surgical procedure, so in pregnancy, how is it planned and how it goes?
actually, in pregnancy, we avoid any major invasive intervention. We advise it's not only the patient which needs to be counseled; it is the counseling of the couple, the family, because it's lot of emotions are linked to it. In such cases, we advise them to get a simplest of all possible procedure which is there. That too in the second trimester. Sometimes in first or third trimester also with the female running high grade fevers, we have to intervene with a caution that there are chances of abortion or early delivery.
It's just what medically is required at that time. So, other than good water intake, so that ensuring a good urine output, there are people who are advised or they are asked to, or rather, I say it's a general parlance that people feel that they should not take calcium because calcium will lead to make more stones. And so, what are your views on calcium vis-a-vis stone formation?
Actually, calcium in a medical doses which we advise usually doesn't lead to any stone formation.
Okay.
Right, one should not restrict himself or herself from taking calcium. Rather, we advise to take at least a minimum level of calcium which is required for the body. If not taken, the other serious consequences like osteoporosis, bone pain can be there. Okay. Right, directly calcium intake is not linked to stone formation if you are taking them under medical supervision in the medical doses.
Although calcium stones are most common, but it is not, the stone formation is not related to direct ingestion of calcium. Since we are talking of myths, I would like to go for a most common myth that taking lot of beer treats the stone. So if you can just tell how it works, that flush therapy and all.
Actually, whosoever comes with the pain of stone usually take couple of pint of beer to expel it out. So the problem taking of beer is that taking a couple of pint or 3 to 4 pint of beer is not difficult for anyone. But drinking a couple of liter of water is a tough job. You get bloating of abdomen, you get nausea, everything while you drink a water. You can add little salt or some lemon to the water and you can take a couple of water. The same thing happens with the beer. The problem with the beer is that beer itself is made of malt, which is itself is an oxalate. And the second component which we say in stone after calcium is the oxalate thing. Okay. So drinking beer, initially it will increase the urine production, it will increase the urine output. But post that, there will be overall dehydration in the body if not supplemented with plain liquids. So in the next day, the patient will be again predispose himself to the formation of stone.
And overall flush therapy is something which we use today also?
Flush therapy was done around a couple of decades back to give IV fluids and some injections to increase the urine output, to flush the urine out of the body. It has its role in a couple of years back when the surgery was quite fearsome. Now the endoscopic surgeries is there is no cut, they are so simple surgeries. The problem with the flush therapy is if intrarenal pressure rises, it can lead to perforation of soft part of urine. You can develop a urinoma, that a collection of urine around the kidney. That can be sometimes difficult to manage.
By any means, when flush therapy is not no more indicated, so taking beer is not at all warranted. And as a medical fraternity, we understand that alcohol has its own side effects. Moving ahead, before going to surgical treatment, I do understand that surgical is the mainstay of the stone treatment. But if you can put some light on what all conservative managements which are being used, and is there a role of size of stone, location of stone on the treatment?
Definitely, the size of stone, the presentation is when the stone is in the ureter or the urethra. Either it obstructs the urine out of the kidney or out of the bladder. The patient presents to us like this, or incidental finding of stone in ultrasound is there. So what we do is, we practice that if the size of stone is less than 5 mm, we let it to get it out by itself by drinking plenty of liquids, supplementing it with some drugs, giving painkillers to the patient, relaxants to the patient, that the stone expels by itself. But if the stone size is more, swelling in the kidney is more, patient have high grade running fever, recurrent blood in urine is there, and his job is that he can't afford the pain and he can't reach the emergency early. In such professions, even we say that the pilots and the merchant navy people, are to be screened before going to their flight and everything.
So there it is simply no stone, whatsoever the size is.
Exactly, whatever the size is. Because 3 stone will cause a severe pain, and if a
job is so critical that you cannot.
You can't.
Got your point. So, are there any conditions in which, other than job related, like pilots and much in you said, are there any other conditions which warrant an intervention at say less than 5 stone?
Valid question, Dr. Prashant. The patients with the solitary kidney, that it's a congenital malformation. A solitary kidneys can be there. Previous surgeries can lead to nephrectomies, can lead to a person on solitary kidney. Requires aggressive stone management, surgical stone management. In such cases, we don't try conservative treatment. Other thing is that the persons with bilateral ureteric stones, with bilateral mild swelling or something like that, they require aggressive treatment. Urethral stones, patient is not able to passing the urine, there is difficulty in passing urine. That will lead to retrograde changes in the kidney. Those two require urgent intervention.
We understand that at times patient don't know that they have a solitary kidney. It's just during the stone time when they came over there, and the ultrasound also, it came to knowledge that they have a solitary kidney.
True, because of the screening ultrasound done at the time of acute pain, they came to know that they usually get into that we have a single kidney. In such cases, intervention is required.
Moving forward from to the treatment, that is the surgical treatment, which is the mainstay of the renal stones or all the stones which you treat. So can you please just help our viewers from the jargons of RIRS, ESWL and all, that how it works, which location, which therapy, and also please do put on some light on laser.
The management of renal stone can be divided into 3 parts. First, pertaining to kidney. Second is the tube connecting the kidney and the bladder. Thirdly, the bladder and the urethra, from where we pee out. For kidney stones, ranging from ESWL, PCNL and RIRS. I will give you a brief overview of all the 3. In ESWL, it's a totally non-invasive procedure in which we break the stone extracorporally by shock wave. We take the patient in a OR, we adjust a machine over him, we give a shock wave to the particular stone and break it.
I do remember when we were doing MBBS, it was something which was lot of talked about, that no incision and all, and ESW is going to be a very good therapy.
True, actually armamentarium was not that great at that time. So ESWL success rate of 70% was considered to be very good a couple of 3 decades back.
Okay.
But now such a fast lifestyle, everyone wants a good success rate of stone removal. They want to be stone free. So ESWL is now going little out of use, little out of fashion, you can say that. Then the person want a stone to be removed as early as possible. In the second surgery, which I told you is PCNL, that is percutaneous nephrolithotomy, to put a cut in the back. It's a small cut which allow a pen-like scope to go inside the kidney.
Okay.
We see the stone visually by a camera, and we break the stone, we remove the pieces of stone and put a stent.
How do you break the stone as such?
Actually, breaking the stone has their own ways. One is the laser, which everyone says that I got a laser done. And other is a pneumatic, which is the old time testers thing. For percutaneous nephrolithotomy, depending on the size of stone, we can do in both the ways.
Laser is something which comes after when you reach the stone. It's not something what our kids do, that you point a laser and you get the stone.
It's not like that actually. The third thing which I told you is RIRS. It's one of the latest addition to the armamentarium of a urologist, in which we go from the natural orifice to the kidney. We tackle the stone over there. We crush the stone over there. And now suction is also available to suck the dust out of it. And the stone free rates of these 2 procedures are more than 90%.
Oh, that's great. As you talked of stone free rates, I will just like to ask about the recurrence of stone. Probably that is something which will be required for our viewers to know.
Actually, a person once get a stone disease has a chances of more than 50% to get a stone again in couple of years. And overall recurrence is 60 to 80% in lifetime. So stone has a high recurrence rate because everything depends on the patient's way of eating.
Lifestyle is not that easy. Yeah. So although a lifestyle disease and hence high recurrence. Okay.
The second thing, we are coming to the second part of managing the ureteric stones. For ureteric stones, ureterorhinoscopic surgery is done, that is called as URS. That is too done with the natural orifice. If a ureteric stone is quite large, then laparoscopy can also be done to remove the stones.
Just for the viewers, laparoscopy is a procedure in which we go through cameras through small holes in the abdomen.
Yes, it's like that. And finally, coming to the bladder stones that are easily tackled by the natural orifice, and stone-free rates are quite good in bladder.
And how's the post-op thing in these procedures? Patient has to stay how much time in the hospital and back to work in how much time?
ESWL is a OPD-based procedure. 2-3 of sittings are required for ESWL. Patient can right away go to the job after getting a shockwave done the very next day. For PCNL, we advise a rest for 5 to 7 days. That prevents bleeding because kidney, as you know, takes around 20% of the heart blood. So to prevent bleeding, this rest is required. And we tell them to avoid lifting of heavy weights and doing strenuous physical exercise for a month or so. For RIRs, again, it's a very good procedure. A patient discharged from the hospital, if willing, can join the job the very next day.
Oh, that's great, man. That's a good recovery time.
The other thing is, the myth is that stent is placed. The urology stent is totally different from the cardiac stent. Anything which passes through the obstruction is called a stent. So a stent is placed to remove any small fragment left in the kidney and to prevent any obstruction in the kidney because of the blood clot, which is usually done in all the stone patients of, we say, that upper tract, that is ureter and kidney. Stent itself can cause some urinary problem. It can cause some blood in urine. It can cause some pain while urination.
Drugs that is more of that patient should know that these things 5%
happen. 5% of the patient are very sensitive to the stents, and they require early removal of stents also. Usually we remove such stents in 3 to 4 weeks time after surgery.
Okay, so patient is discharged as per the surgery, and 3 to 4 weeks they have to come on an OPD basis. The stent is removed. So before finishing the stones, I will just like to know, is there any linkage of infection with the stone? Urinary infection?
Yes, infection is a totally other part. Definitely stone is one of the reason of infection in the kidney because stone doesn't have its own blood supply.
But it becomes a nidus.
Yeah, it's a nidus for the bacteria to grow, which leads to recurrent urinary tract infection in a patient. So urinary tract infection itself is a very broad topic in urology, and it's also one of the commonest presentation of the patient with fever, burning micturition, difficulty in voiding, and all those things are there. So what we usually do is the screening with ultrasound to look for all the systems are in place. There is no nidus like stone is there or some other development of any abscess or any mass in the kidneys can be taken care by the ultrasound. Secondly, we get the urinary investigation done in cases of UTI, that is urine culture is must in such cases, and we start the patient with the basic therapy which is prevalent in our society. That is called our general sensitivity we see in the public.
Yeah, because culture will come in it's 2 days. So
sometimes such patients too require hospitalization for injectable antibiotics because the fever is such a high grade in urinary cases. Infection of the kidney that is called pyelonephritis can be really threatening. It is also painful. One presents with the pain in the flank region that is very severe. And in such cases, there are some clinical signs which can give us an idea that the patient is suffering from it.
Now, switching over to our next topic, which is also a very common concern, that is overactive bladder, where a person has an urge to urinate and unable to control that urge and has to run fast to the washroom. So, can you please elaborate on how it presents? What are the common causes of overactive bladder?
Yeah, overactive bladder is the other common thing which we see in our OPD, and as the life expectancy is increasing, our sedentary lifestyle is there, stress is there in the life of everyone, the incidence is very high. We are even seeing young children pre-examination, they are presenting with such symptom of frequent urination, not able to pass urine properly, and the increase in weight of children, we are seeing obesity in children, overall obesity in the population, intake of caffeine, and taking tobacco products, that induces irritation in the bladder. Even chilies taken in high quantity can cause irritation of bladder, and patient may present to us with overactivity of a bladder.
Going forward, one is you said about lifestyle. Other thing you said about the age, that age expectancy is increasing. So overall overactive bladder is increasing. So I do understand that prostate causes overactive bladder, and because of prostate symptoms, there will be overactive bladder. Is there anything which causes overactive bladder in females?
Yeah, post menopause, there is, you can say that there is, the mucosa goes little hard. The obstruction is there also in females.
Okay.
Stressful lifestyle in females also. These are the predisposing factors in female which can predispose to overactive bladder. And the urethra of female is small as compared to males. The infections female take care more as compared to males. Infection predisposing to overactive bladder, recurrent UTIs. These are the common things which are in females.
So if I talk of non-pharmacological things which matter for an overactive bladder is that you should be more caution about stress and your caffeine
Healthy
intake should be-
lifestyle, having a proper weight, doing proper exercise, balanced diet. These are the things one himself can provide. Can be a doctor to himself for this condition.
Taking the cue from that overactive bladder, moving to prostate, for the viewers, I'll just like to tell, prostate is an organ which is there in males and helps in the fertility of male. There are so many things which we talk of prostate for an old age male, that prostate ki problem hai, etc. So how do you look at prostate problems and how to cover this whole, it's a complex of disease, continuum of disease. So how it presents, so if you can just put some light.
Actually, the prostate is a organ which is present deep down in the pelvis of male. You can say that after the bladder, the next is prostate, then is your urethra from where we pee. Enlargement of prostate is there seen in mostly in the 6th decade of life. This leads to obstruction of the urine flow from the bladder to the penis. This obstruction leads to some changes in the bladder. The bladder behaves like a pump which is increasing its capacity, increasing its power to push through urine out of obstruction. So the presentation is frequent urination is there, urgency is there, nighttime urination is there. These are called the irritative symptoms of the prostatism. The others are obstructive symptoms, that one has to strain to pass the urine. One flow decreases, there is intermittency, the urine stop and go. This is the complaint which patient presents. And ultimately this leads to increase in residual urine of the bladder, because the bladder is made to empty the urine completely. But because of this, the bladder capacity to pump out the urine decreases with time, and patient land up in retention of urine.
Prostate can present like so many symptoms. How do you define treatment? How do you look for investigations first? How do you investigate a patient who is having symptoms which may be looked at like a prostate symptoms?
A patient comes to us with difficulty in voiding, waking again and again at night, not able to pass urine properly. The first investigation, we get ultrasound done to look for exactly what the size of prostate is. Is there any residual urine in bladder, or there is some changes in the upper part of the kidney, that there is some swelling is there or not. Then we advise them to undergo a test that is called uroflowmetry, that measures the flow of urine, the speed of urine, and there is a graph to know that which we compare with the population, that it comes under the obstruction part or it comes under the normal part.
ECG for a urologist.
Yeah, it is. You can say that. You can say that it's a ECG of urologist, and for a prostate patient, and frequent uroflowmetry and frequent ultrasound examinations are required to get proper treatment for follow-ups also. Thirdly, we get some blood tests done, that is PSA, the most talk about test in prostate. It's a blood test to rule out any malignant part in prostate is there or not. It's a screening thing, although it get increased in other conditions also. But for an old age patient of more than 60 years, high PSA level without any infection in the body, pertain more towards the cancer side.
When you get, say, a uroflowmetry done, does the results of uroflowmetry decides the type of medicine also?
Not exactly. The results of uropneumonia decides that a person requires some form of treatment or not. Giving a medication, we repeat the uroflow, we see the change in the flowmetry pattern, we see the change in the symptomatology of the patient. If patient is comfortable with that flow, we continue the patient with medication. And if the flow is quite poor, the residual urine is increasing, and patient is not satisfied with the medication, we advise them some surgical intervention.
And if PSA is high, as you said that PSA increases in infections also, and we know that although the cutoff value is 4, but by experience, I have also seen patients having 35 PSA, but still an infection was there. So our urine culture followed by PSA is something very commonly seen if it is not very high. If PSA is high and urine culture is negative, how it proceeds further?
Actually, in Indian population, what I practice is that I repeat the PSA level after a couple of weeks of giving some basic antibiotic to look for that there is any fall in PSA or not. Because chronic prostatitis and acute and chronic prostatitis is quite common in our population. If the repeat value of PSA is quite high, we advise them to go for biopsy.
So biopsy is a procedure by which you take a tissue out of prostate
Exactly.
and look for cancer in it.
There are two school of thought nowadays. If you get a PSA above 4, you can advise a MRI also for specifically for prostate, because we can now get the screening for we get a good screening for with the MRI also to rule out tumor or not. That is called pyrite scoring. According to that score, we decide that this patient requires a biopsy or this patient can go with the conservative management or basic surgical intervention.
Moving ahead on, as we know that prostate is an organ which responds to testosterone and keeps on increasing physiologically, and at times just benign prostatic hyperplasia, and at times it is prostate cancer. So moving ahead on prostate cancer, can you please elaborate at what age group generally you see prostate cancer, and does it has any genetic linkage when it comes to prostate cancer?
Usually, prostate cancer is seen in sixth decade of life, and prostate cancer is the commonest cancer in men in whole of the world with a very high incidence. And coming to the genetic predisposition, definitely the genetics do play a role. There are few genes now. Genetic markers are also done. Few genes which are linked to the prostate cancer. Other predisposing factor is the family history of prostate cancer. There is some association with the refined diets. You can say that red meat or something like that predisposes one to. There is some association, but that has still not proved. So, in my opinion, for prevention, one can get a good raw diet, to take raw diet, balanced diet. That's a better thing.
And how's prostate cancer generally managed? Is it primarily a medical management or primarily a surgical management?
After the biopsy, we get scoring of the histology of that slides. That is called Gleason score. And according to the Gleason score, we manage the patient. We get sometimes we get a PET scan done to rule out there are any spread of prostate to other part of the body. Management is usually divided into the metastatic, that has been
one which has already moved out
of the body, and the other is the localized tumor. For localized tumor, as a surgeon, I advise surgery. And for metastatic, there are some injection therapy now. A drug is also there, oral therapy, to remove the testosterone from the body to get a benefit of it.
As you said, prostate cancer is one of the most common cancer, and we do understand its linkages with genetics and all. Moving ahead to other cancers which a urologist encounter, like bladder cancers, renal cancers. Let's talk about bladder cancer a bit. Its linkage on the basis of lifestyle or on the basis of genetics?
Usually, bladder cancer is linked to tobacco. So, a person smoking or chewing tobacco, taking tobacco in any form, has association with the bladder cancer, more chances to get a bladder cancer. And the presentation of such person is usually 6th or 7th decade of life, having painless hematuria, coming to OPD with just a little lower side of hemoglobin, and with history of smoking with cigarettes.
So primarily a silent disease which just take over, and
true. Again,
it's just a watchful eyes which requires
again investigated in the form of a ultrasound to get some growth in bladder, then CT scan is done to get further notification of the disease in other part of the body, and then intervention is must in bladder cancer.
And its primary treatment is?
Again, for any oncological treatment to start, we need to prove it first.
Yeah.
We go inside the bladder, we cut the tumor. That is done endoscopically. We cut the tumor and we get a biopsy. And according to biopsy, if it is been into the muscular part of the bladder, we advise to remove the bladder. If it's in the upper part of the bladder itself, then that can be managed endoscopically itself with a good follow-up.
Prostate and bladder cancer are primarily cancers of old age.
Yeah.
What about renal cell carcinomas and other cancers of kidneys?
RCC is that renal cell carcinoma. In the short form, we'd say RCC is seen in 5th decade of life. And the presentation is the incidental diagnosis of some mass in kidney or some swelling in kidney. We don't see now exactly the big masses palpable by abdomen because of the easily availability of ultrasound. The patient comes to us sometime with blood in urine. Sometimes there is anemia, raised ESR, such things we see in our day-to-day practice, and they are usually managed surgically.
So what I can make out from what all you're telling is, for all old age patients, they have to be very, very cautious on all the symptoms and not to neglect any painless hematuриas. They should consult a urologist and get investigated properly to rule out any
Screening oneself for, I say, a yearly health checkup is a good idea after 40s.
Yeah.
To diagnose cancers early.
Yeah, PSA is part of most of the checkups, blood checkups, and
true.
USG abdomen is there, so these things can be picked up pretty early.
True.
And we all understand that any cancer which is picked early has a far better survival rate than.
Exactly. The outcome is really good. The morbidity is very less because of the advances in the surgical techniques and surgeries. The patient can take advantage of it.
As you talked about advancement in surgeries, we all know that robotics is synonymous in urology. Can you just tell about something about how robotics is working in urology part?
Actually, first the myth with the robotics is that the robot does the surgery. It's not the robot that does the surgery. The consoles are in the hand of a surgeon. And another surgeon is standing just besides the robot, assisting with the 4th or 5th port. Basically, the invention of robot was done for the places where our hands are quite broad, where the space is less. So pelvis in the body of male or female is a narrow area, and getting into the prostate with open surgery was quite difficult. In robot, we can go inside the pelvis, we can take care of all the vessels and everything.
So far better maneuverability.
Far better maneuverability can be done. Good control of diseases there, good surgical outcome, and overall the morbidity of patient. The patient is discharged within 48 hours with such a big surgery.
Man behind the machine is important, we do understand, and machines are helping us a lot. Moving ahead from the dreaded topic of cancers across, we'd like to talk something about men's health or men's sexual health, which is also an area which comes a lot to urology. So if you can talk about the most talked about men's sexual health problem is premature ejaculation. So if you can throw some light out there.
Yeah, premature ejaculation is a thing in which a male get a ejaculate out in a very early time. It usually the average intravaginal time which we consider worldwide is around 4 to 5 minutes. And if we go by definition, if it's less than 2 minutes, we label it as premature ejaculation. I feel it's more of a satisfaction of a patient and the partner, which one can define it as a premature or it's a normal. And with the prevalence of all the pornography and all those things, and comparing yourself with the other person is adding to the patient load of this symptom. In premature ejaculation, more of a counseling is required, not only to the patient but to the couple, because the performance can never be always 100%. It waves around. A single episode of premature ejaculation in a month is not a problem.
Yeah, it's more of a perception thing which couple needs to understand.
Exactly. And the confidence of a couple is there. There shouldn't be any discord between them. The proper environment is there. Less of stress. Physical activity should be at their own comfort. Such things adds to this.
And from premature ejaculation, there is something called as erectile dysfunction, which is also a very common thing. and probably at times linked to premature ejaculation also. So if you can put some light out there.
Usually, a person coming with premature ejaculation has some element of erectile dysfunction in him. It is usually there. Uh, as the age is increasing, the lifestyle, stressed lifestyle, late working hours, obesity, other comorbidities like cardiac diseases, some medication which can lead to erectile dysfunction. So there are some drugs which are available to us that erectile dysfunction can be taken care of with those drugs. Secondly, a good counseling and with a good healthcare worker is a must, which is required. First of all, such patient needs to visit their urologist. They will manage it with medications, counseling, couple counseling, and sometimes psychotherapy is also required.
Just moving forward on this topic of men's sexual health, we'll also like to know your views on usage of 5-phosphodiesterase inhibitors like tadalafil. People use it for recreational. So, what all side effects it may have? Why it should be discouraged?
First of all, the thing is there is drug overuse can be there because taking a pill doesn't make you stat. Person can have a drug overload, and usually the person using it for recreational purpose is also taking some other thing like alcohol or marijuana, which can lead to persistent erection that is called priapism. That can be really dangerous for the patient, and such emergency intervention is required in such type of patients. So such drugs should always be under the cover of a physician with all the workup, if required for cardiac workup is required, is done properly, and all the side effects of the patient to the patient should be known to patient in details.
You said about cardiac workup. So, these drugs affect the cardiac working?
It's not exactly. I don't say that it affects cardiac working, but as act of sex is increases the workload on our heart. It increases our heart rate. If a patient is a known case of some cardiovascular diseases or some,
Then these drugs are contraindicated.
not contraindicated, that to be taken care of with the
Yeah.
consult of a urologist and a cardiologist.
So, Dr. Rishi, you talked a lot about diseases affecting kidney, bladder, prostate. Primarily, all the diseases what I'm seeing are getting involved in 5th decade, 6th decade, 7th decade, or a stone which can come into a say at an age when you have started working, you're doing a lot of exercise, etc. We'd like to know where all urology comes into play when it comes to kids. That is urology, pediatric urology, like nocturia, phimosis, etc. So, if you can put some light.
Pediatric urology itself is a very broad topic, and pediatric age group is a very tender age, and first of all, you need to screen the baby for congenital malformations.
Yeah.
It can pertain to PUJ obstruction, that is pelvic ureteric junction obstruction, leading to kidney swelling, which is diagnosed in antenatal period of in womb itself.
At the trimester scans, the anomaly scans.
Anomaly scans. In the anomaly scan, one can get into it. It can be because of posterior urethral wall obstruction leading to swelling in the kidney. It may be hypospadias. It may be undescended testes. There are multiple things. But the common thing which we across in pediatric age group is bedwetting. That is called nocturia. Around 15 to 20% of the kids have this problem, which usually get cured by 5 years of age by itself. Scolding the child, giving stress to the child adds on to the years of the symptom. 1% of people with kids with till 15 years of age can bedwet. That too can be taken care of some medications, counseling, behavioral therapy to the kid, and to the parents counseling itself. The other thing which is seen in the OPD is difficulty in retraction of the skin of a penis.
Yeah, ballooning of that skin.
That is called phimosis. Usually in our culture, we don't go for neonatal circumcision, because in some countries it's a common thing nowadays. The option is given to the parents to go for circumcision, because in males, because of phimosis, there is recurrent UTIs. Recurrent UTIs leads to scarring of kidneys, leading to kidney diseases, leading to sometimes hypertension in older age. That can be prevented with that. Till 5 years of age, the skin is usually stuck to the glans area, and we wait till 5 years of age that skin can be go back. But if a child develops a UTI, recurrent UTI is there, ballooning of prepucial skin is there by the mother, the history given by the mother, we intervene and we do circumcision in such cases.
And in present strata, uses of diaper is high, so ballooning is not seen and missed by the parents, and at times it leads
the
to...
child usually cries while passing urine, and at that time, sometime mother sees it while giving a bath. If a mother tries to reduce that particular skin part, it's not possible. She may not able to see the area from where urine is coming, and such are the usual complaint of the parents.
So, a very good coverage across in this short time of 40-50 minutes. We'll like you to sum up the whole, how a person can be more preventive, more active for a healthy kidney, or from a urologist point of view.
From a urologist perspective, I will say that the first thing what viewers can do is to drink liquids. Stone is a common problem that can be taken by a simple thing by drinking plenty of liquids, reducing salt in diet. So getting 2.5 liters of urine a day is a good thing which prevents formation of stone. Secondly, the abuse of painkillers. It's quite common nowadays. Having a small pain, you take a painkillers. So taking painkiller over the counter can be counterproductive to the patients. So if recurrent painkiller is required, see your physician, see your urologist, see any medical specialist for better management of pain.
Yeah, these all are excreted by kidney, creating a load and ultimately damage to the kidney.
Many a time, patient with renal colic comes to us with raised creatinine level. That is sometimes terrible. That even dialysis may be required in few cases. Thirdly, tobacco, any form, chewing or smoking, any form. Nowadays, even youngsters are going with electronic cigarettes. That too is not good.
Yeah.
So tobacco itself is predisposing cause to many cancers, not only urological cancers.
Yeah, I was reading there are 20 cancers which are directly linked with tobacco.
Exactly. So with we have such a polluted atmosphere in our cities now. We are already smoking too much charcoal in ourselves. So adding that to smoking to it is very worrisome. It's my personal request to all my viewers to at least not to take any form of tobaccos. And finally, for old age patients, for the patients who have entered their 50s, early 50s or 60s, they should go for a preventive health checkup. They should not take any symptom lightly. Any single drop of blood in urine or any difficulty in voiding, any pain in abdomen, that needs to be addressed properly. And with this, I say that yearly health checkup after 50 years of age or after 60 years of age is a good thing, and we can diagnose things early. We can manage things in a better way with giving good quality of life to our viewers. So in the last, I can only say that just be healthy, be fit, do good physical exercise, drink liquids, avoid NSAIDs, and routine health checkup. This is must for a good future, good non-morbid life.
Thanks a lot for this insightful summary of the whole session. Thanks, Dr. Rishi.
Thank you, Dr. Prashant.
Thanks, viewers and listeners, for tuning into this podcast. Hope we all have healthy kidneys. Stay healthy, stay wise, till we at Tata MG bring care to health.